People who join us, but I'm just going to share my screen and if I can press all the right buttons, we will be going well for this time on a Monday. So look, thank you very much, everybody, for joining us. I'm really looking forward to today's session that's going to be led by Professor Julian Trollor. He's going to be talking us today about translating research evidence on health inequalities into benefits for people with intellectual and developmental disabilities. But just before I hand over to Julian, I'd just like to acknowledge the traditional custodians of the land of wherever you happen to be. For me, I'm down in Melbourne, and I'm on the lands of the Wurundjeri people of the Kulin Nation, and I'd like to pay my respects to elders past and present. So if I stop sharing, and Julian, if I hand over to you, if you wouldn't mind introducing yourself to the group, that would be great, and looking forward to hearing you talk.
Thank you so much, Stephanie, and thank you so much to the group for this invitation. I'm really privileged to speak to you today and talk a little bit about the research program that I lead. It's wonderful to see some familiar names and faces online, and so I'm really excited about today. Perhaps before I start, I'd like to acknowledge the Bidjigal people, the traditional custodians of the land here at UNSW, and acknowledge elders past and present, and any First Nations people present today, but also acknowledge the significance of cognitive disability for First Nations people nationally. And the vision that we have as part of the development of the new national centre that I have the privilege of leading is to embed a cultural model of inclusion for First Nations people throughout that work. I'd also like to acknowledge people with lived experience of disability and those who support them, including anybody present today. If I could just confirm that my screen has shared effectively, Stephanie, I did press the right buttons. Thank you. That's wonderful. I'm a medical practitioner by background. I started a career in more fundamental neuroscience, and I've continued to some degree to work in that space, particularly in research, looking at cognitive disorders as they affect people, particularly in later life. But in more recent years, I've had a really interesting journey focusing in from my broad remit in neuropsychiatry to population groups of people living with intellectual or developmental disability. And that's come about rather by accident. It has always been a core part of my clinical work, but it wasn't until 2009 when our New South Wales government invested in a new chair of specifically intellectual disability mental health that I had the opportunity to take on that role and gradually broaden from a mental health-based program of work through to a whole of health and population health focus on people living with intellectual and cognitive disabilities. In more recent times, because of the discussions we've had over time and the pairing of our work with advocacy, we've progressed discussions with the Commonwealth Government to the point where there's been investment in a new national roadmap to improve the health of people with intellectual disability. And as part of that, some series of initiatives have been funded, including a new national centre of excellence in this area. And with others, I've had the joy of applying for that competitive funding and receiving it to host this centre at UNSW with 9 consortium partners and 56 collaborating and partnering organisations. And so that's where we're at the moment. I'm going to talk a little bit about that journey, what it's looked like, what some of the insights have been in relation to the health needs of people with intellectual disability specifically, because I think that's the easiest test case here for knowledge translation. I'm not pretending to be an expert. I've learned so many things as I've embarked on this journey, and you might have insights that you are keen to share about how I could do it differently or better. I'm always interested in thinking about how to improve the way we're operating, and I'd really welcome that candid feedback and discussion, hoping that there's time to do so. So I need to acknowledge funding that comes to us generously from both the New South Wales Ministry of Health and the Australian Government Department of Health and Aged Care, and of course the National Health and Medical Research Council, as well as other government departments and from time to time other agencies, regulatory authorities and funding bodies. And I'm really grateful for the funding investment over time that has enabled us to do great work as a team. I'm going to talk a little bit about what intellectual disability is, so we've all got a shared understanding, and talk through research findings that have really helped us drive the changes that we're now seeing, and to talk about how we've used our findings strategically, and then just to reflect on some of the key enablers of the approach. So firstly, what is an intellectual disability? Many of you will appreciate that this involves essentially three core elements being present: below average intelligence, deficits in functioning, and an onset during the developmental period. When you combine those things, on average, about 1.8% of the Australian population probably has an intellectual disability. Estimates vary, and I say estimates because we have really no robust data at a whole of population level nationally. Good data from Western Australia, from my colleagues at the Telethon Kids Institute, would suggest that the prevalence is slightly higher at around 2.2% on their latest paper. Most estimates internationally suggest about 1% of the population have an intellectual disability that requires some degree of support by a system in place for support, health or disability or other. The population is a very interesting one, and it's incredibly varied. And this is one of the challenges we have in implementing findings into practical benefits for people with intellectual disability. Most people living with intellectual disability have very mild levels of disability, 85% of that population. And of course, as we go through more severe levels of disability, we see a different health profile associated with that group, different determinants of health outcomes as we go down that level of disability, and increasing complexity, particularly around the physical health issues. But this population is really diverse. It ranges from people with core genetic syndromes as a cause of intellectual disability, such as people living with Down syndrome, right through to people who have mild intellectual disability due to multiple factors, including some elements of influences in the developmental period, and factors such as use of alcohol during the gestation, through to people who have had a typical trajectory of development up till a point when something critical has occurred, such as meningitis as a child or a younger person, or traumatic brain injury as a younger person. And then the profile for that person and their needs are distinct. A person who's had typical development to a certain phase and then had a critical insult to the brain has a really different range of issues to somebody living with a complex disability related to a genetic syndrome. So you can see that the experiences vary. We see a tremendous variety of health literacy, both in the person themselves and those supporting them. We see a diversity of experiences with interactions with the support systems, including a lot of people with mild intellectual disability, for example, having key contact with the criminal justice system. And we know from our data sets that we see overrepresentation of people with intellectual disability fourfold in the justice system. And we know that the vast majority of people in our prisons in New South Wales with intellectual disability, 53% of them, in fact, are First Nations people. And so those people with intellectual disability in that context have completely different characteristics and health needs, dominated particularly by mental health needs and alcohol and other drug related support needs. Though I'm going to talk at a population level, so I'm going to put this, what I see as a lifespan health disadvantage into perspective. So on average, we expect, as people living today, to live, hopefully on average, into our early or mid-80s. But for people living with intellectual disability, frailty is brought forward on average 25 years, and death, we know, occurs at median age that is about 27 years younger than the general population. And this finding, particularly from some of our recent work, has been one of the key bits of data that has enabled us to talk meaningfully to bring about some change. When we think about the causes of death, we understand these causes of death are death from typical things that the general population experience: cardiovascular disease, infections, cancers, and so on. And when we look at potentially avoidable deaths in our population, as we have done with our data, we've seen that the proportion of potentially avoidable deaths in people with intellectual disabilities is actually double that of the general population. So at the time we did our study, we found that 38% of all deaths in this population were from potentially avoidable causes. And that is quite a remarkable finding. It's double that seen in the general population. And when you start to piece that together with other data from the primary care system and knowledge about the types of conditions experienced by people with intellectual disability, we can appreciate that the end point of death represents really a lifelong health disadvantage that is multifactorial, both in terms of social determinants of health as well as other determinants such as lack of access to healthcare which meets the person's needs. There's a particular gap in the area of preventive healthcare. So what are some of the research findings that have been really helpful in driving the narrative on need for change? Well, I've tried to summarise some of our projects to date and then some of the things that are in the pipeline on this slide, trying to look at each of the domains of basic epidemiology, understanding of risk factors, which we've probably underdone, contextual determinants of health inequality, formulating and testing of interventions and their knowledge transfer. And I've tried to illustrate how we've chipped away. And you might think, oh, this matrix looks so systematic and logical. But in fact, really what it represents is us pulling together bits of funding where we can, driven by an overarching strategy, but really working opportunistically to pull in different types of funding to do the work that we think needs to be done. And I'll try and explain how we've developed over time a greater capacity for co-design in that mission. It didn't start as a co-designed initiative, but certainly it's progressed there. What we've had to do is one of the core and central aspects of this is trying to work out a way of identifying this population. I said earlier, this population isn't represented well in our national data sets. In fact, until recently, our Australian Bureau of Statistics has conflated dementia and intellectual disability into one category, labelling it intellectual disability, and reporting national statistics that are just fatally flawed. And so they don't represent the health needs of this group at all. What we've had to do is to realise that people with intellectual disability are represented in different services systems across our state, and we've had to pull in all of those data sets to link them together. And that's been done by the Centre for Health Record Linkage, and now also through AIHW to bring in Commonwealth data sets. So we've been able to see over 11 different data sets build that population profile, including using data sets from our justice system, data sets from disability-related data, such as our state's minimum data set for disability, our state's data set for supporting decision-making, our state's data set relating to reporting to our ombudsman, combined with other health data sets, for example, emergency department, inpatient stays, ambulatory care data, and bringing those things all together with other bespoke data sets, mortality data, cause of death data, justice system data, Department of Education data, and so on. Bringing all that together. Once we do that, we have a near population capture. We pull into our data set currently about 1.2% of the population with intellectual disability, and we now have built that data set to a point where we have 500,000 controls, so and they're matched for basic age, sex, and socioeconomic factors, and then we're able to make direct comparisons with a really useful population. That's been an enormous journey to get there, and now enables us to really draw direct comparisons, look at trajectories through healthcare, look at things like predictors of health outcomes, look at continuity of care and its impact on outcomes, look at things like prescribing, particularly of psychotropic drug prescribing and its influence on disease endpoints, look at things like cardiometabolic disease burden and how to prevent it, with our data, and that's the way we're moving at present. In bringing together those data sets, we've appreciated a couple of things. The first is the dominance of mental health concerns in this population. These are just basic prevalence statistics for core mental disorders sorted by ICD 10 broad categories. And you can see the purple represents people with intellectual disability, the blue people in the general population. You can see a tremendous uptick in mental health concerns for this population across all of the range of mental health conditions that is typically reported, including when you get down to things like dementia. So you see the prevalence of dementia in this group is way in excess, and not all of that is driven by the high prevalence in people living with Down syndrome. It seems to be across the boards, particularly for those with Down syndrome, but also across the board. You'll also note here that autism is a very common co-occurring condition with intellectual disability. And this is one of the other aspects with this population. So sometimes the population identifies intellectual disability as a secondary disability and something else as the primary. An example would be autism as a primary, cerebral palsy as a primary, and intellectual disability as a secondary. So in some of our data sets, what we need to look for is not just a primary label. For example, if you're looking at NDIS data or dashboards, is thinking more broadly about does intellectual disability feature in any of the labels associated with that person in that system. We have engaged in a considerable body of work as a team looking at the mental health concerns and barriers and enablers to access to mental health has been one key area of exploration. And what we've done over time, we've used our data to examine the mental health needs. We've done some costings, which has convinced some governments to invest in better mental health service provision in this area. We've understood the barriers and enablers to access, and then we've been able to use that information and scoping studies to design, co-design approaches to new health services, new mental health services. And we're really pleased in New South Wales that at a level of state-based services, we've been able to convince our health department to invest in new models of care based on our scoping work and design of those services. And we're really fortunate now to have completed that cycle to now be in a position where we've funded, together with Karen Fisher's group from Social Policy Research Centre here, to actually evaluate whether those services are doing a good job. So it's an interesting journey coming through from identifying the mental health need, understanding the landscape from the lived experience perspective, understanding the health service use and its cost to our government, through to co-designing a new service, through to evaluating that. That's been an incredibly rich experience that's taught me a lot. Earlier in career, I guess if you'd asked me about my passion that was in neuroscience, I've had to, of course, be flexible and develop an awful lot of new skills in order to try and make sense of this and to lead a program of work to do this. And I think some of the enablers, I think, are being able to learn or appreciate new skill sets, your own limitations, and when you need to ask for help, I think would be one of my key reflections. Just to illustrate some of the metrics we've been able to pull out of the data, we've been able to see that people have long admissions to the mental health awards. They're 5 times as likely to experience ultra-long stays, twice as likely to be admitted more than 3 times a year, 2 times as likely to be admitted, and they stay twice as long in our system. And the profile of those individuals looks different to the average mental health service user in our data. We've been able to put that into some meaningful publications. This is one which just took all people with mental health conditions in New South Wales and then looked at how people presented with their first ever mental health presentation to our mental health units, and appreciated an overrepresentation of people with intellectual disability. And then we looked at what happened to them subsequent time windows. We looked after discharge at what happened at 1 month, 2 to 5 months, and 6 to 24 months after that index admission. And we saw that having an intellectual disability was second only to drug and alcohol comorbidities in driving things like risk of representing to the emergency department, and risk of being readmitted to the mental health unit. So essentially, we were able to show there that there was inefficiency in health service provision. And this tiny, in our data set at that point, 1% of the population had a significant bearing on the trajectory through the mental health system. And here's where we started to get a story about actually this small proportion of the population is actually a significant issue for you in the mental health services system. What we did further was actually look at the service use as a whole and the costing to the mental health service provision in New South Wales. So as I said, in our data set, we had 1% roughly of the population at that stage identified with intellectual disability. We were able to show that they were 6% of the overall mental health service user population overall. And we were able to show that the amount of money being used for this 1% of the population meant that 12% of our state's mental health budget as a whole was being spent on this 1% of the population. It was even more profound when we looked at inpatient stays. It was 15% of all of the inpatient mental health costs were being needed to fulfil the mental health service needs of 1% of the population. Now, having statistics like this that really, I think, show some degree of inefficiency in the system, combined with the knowledge that these people come back to our services system because they're not adequately supported on discharge, was a very powerful story, and one that really helped us push our health department to consider better options. I'm not saying we've done that, completed that work. It's work in progress. We were able to show as a proportion of overall health service users in other compartments, including the emergency department and in non-inpatient mental health services, an overrepresentation in these populations as well. And I've already dealt with the mental health statistics, so I won't come back to them. And then we were able to show comparisons with things like standardised rates of presentation to the emergency department and admission rates to the general hospital and length of stay, that the costs were blown out in the general health system as well. This is simply a graph showing all people in New South Wales compared to, all people in New South Wales compared to people with intellectual disability in blue in terms of standardised admission rates per 100,000 persons per year. And so we were able to show that the rate of emergency department presentation was twice that in the general population at double the cost. And we were able to show something similar with the costs of all admitted patient episodes in New South Wales. The average cost, I've had to blank something out that was related to a local health district here. The average cost of admission at that point in New South Wales was down here, below $5,000. It was about $4,900. The average cost here was around about $10,000 for a person with intellectual disability. And so this was further ammunition, I guess, that we had a whole of health system problem that needed to be addressed. When we think about this population, it's one of incredibly rich comorbidity, so multiple problems tend to occur across all bodily systems, cardiovascular, respiratory, neurological, particularly with epilepsy, mental health, frailty and ageing related problems, gastrointestinal problems, and so on. And so we were able to appreciate, and more so through our data when we look at those comorbidities, really what the health needs are. If I could just turn to the mortality data, this has been in three key areas. Firstly, basic mortality statistics. Secondly, looking at cause of death and potentially avoidable deaths. And thirdly, looking at factors associated with death in people with intellectual disability. It's fair to say that when we've showcased the cause of death and potentially avoidable deaths, that we've been able to get significant attention because the causes of death, as I said earlier, are things that would be, I guess, expected in that general population, which not being addressed in this population lead to premature mortality. And in that story was also embedded the potentially avoidable deaths that we're able to categorise. When we think about factors associated with death, some of the factors were logical and able to be appreciated. For example, things like respiratory infections, particularly or including those that are vaccine preventable in this group. Things like epilepsy and epilepsy-related deaths, deaths due to accidents and injuries and poisonings in this population. But we're also able to see that mental health admission was associated with risk of death. So there's an interaction between some of the vulnerabilities, health needs a person may have, including in the mental health space, that makes us think about what's happening in that mental health space. In this group, it's not about premature mortality related to suicide. It's more related to the cardiometabolic impact of being on chronic psychotropic medication, often poorly targeted and often with polypharmacy involved. I want to talk a little bit about some reflections on how we've used the information that we've generated, but some gaps. We tend to live, or I have historically lived, in this little bubble in the middle here of this knowledge translation cycle. And I think increasingly, with the work that we've done and the partnerships we've been able to form, it's forced us to come out more to the outer circle and to think, okay, how do we use the information that we're generating, enable it to get out to the end user who may be able to use it in a way that's meaningful to them. The challenge in my sphere, particularly until recently, has been that we funded for short-term research. We devise our research grant application. If we're lucky enough, we get the grant. It's never enough for the type of research we need to conduct. And then at the end, we produced some great resources, but our ability to promote them and to continue to engage with the community stops the minute that funding cycle is over. And this is, either 3 or 5 years in most cases for us. And so we have a problem in that we're not able to really, we're able to develop some good resources, but we're not able to monitor the use of that information, really evaluate its impact and think, how can we make that sustainable? Because we have, until recently, had no way of really continuing to curate and promote that research. Or if we did, it was very limited. So I think that's been one of the key challenges that we've had to think about. And I think that's where, as part of a new centre that we're developing, the development of a knowledge exchange hub as part of that is really going to help us do that much better. When I think about the way that we've promoted the research, it's been through traditional routes that we're all familiar with, peer-reviewed publications, conference presentations, and so forth. But there's also been some emerging routes. We're harnessing social media to a greater extent. We've experimented earlier with Facebook, which we didn't find helpful. We've used Twitter, though that seems to be fading now, and LinkedIn is becoming much more of a route for us. And I'm sure there will be others. I haven't yet started TikToking about the research. I don't think it lends itself to TikToks. But I think we shouldn't rule anything out. We should always be looking at embracing new technologies and thinking, how can we use them? One of the things that's been incredibly powerful has been using the research in partnership in advocacy. And there, I think, I'm constantly reminded that no matter our research findings, all we're doing is echoing what a person with lived experience can tell somebody. So it's very powerful in our sphere, in our partnership in advocacy, to link with a lead organisation, to have a spokesperson with intellectual disability powerfully telling their story, and simply as the researcher and clinician coming in and saying, to the minister, this is what this person's just told you, but actually we can see that at a population level. And this is the evidence that this isn't just this person's experience. This is happening in a systematic way across a whole population with grave consequences. And that is a really powerful story when you're meeting with somebody, no matter whether it's someone in the government department, a minister's advisor, that starts to help the advocacy agency really drive that change. What we've also experienced is influence in the policy arena. Obviously, you take these results and you feed them into policy revisions, and the best way of doing that is strategic, having mapped your policy landscape, knowing when the policy reviews are occurring, keeping in contact with the relevant government departments so that you're showing an interest in providing that input if and when that opportunity comes, and being ready with a package that you can drop in that promotes the interests of your population group in that policy revision or legislative revision that's occurring. One of the difficulties we struggle with is enough bandwidth to do that strategically as opposed to just reactively. It's often the case that we're just scrambling at the last minute to put something into the policy brief or policy consultation. And I think we need to think, how can we do that a little bit more systematically and strategically? Obviously, there are opportunities to promote systems change. Sometimes they come across in a big way. That is, for example, things like major inquiries, government inquiries into key problems in the healthcare system or for a key population, a Senate inquiry into autism, for example, a Disability Royal Commission or an Aged Care Commission if you're working in that space. And this is a great opportunity to use work and to really put it in a very forthright way in a very high-level public forum. We've also found it quite helpful to build momentum on our issues, hosting national roundtables or key conferences. And that works really well if you have all of the stakeholders, you have the relationships with those stakeholders, and then you lean on them to invite them into those spaces where you come together and those stakeholders are influenced by others in the room. It's very powerful to make sure that that is entirely done in an inclusive way, because you get senior people in government departments sitting aside people with disability or families and hearing directly from them. So that creates, I think, a really nice environment where change can be promoted. Let me move on, otherwise I might run out of time. In our space, building capacity in healthcare is difficult. And it's difficult for so many reasons. It's partly difficult because of the complexity of the population. I think I've illustrated that. But it's also really difficult because there are lots of areas in which intervention is required across lots of different types of health services or layers of the health service. It's also difficult because our services systems in healthcare are divided into age-specific or life cycle-specific phases. And our task is in part very, very early on prenatally prevention, early detection and intervention, preventive healthcare through their lifespan, really, through to thinking how you can do later life well, including in different systems like palliative care. We've just finished a major project that has scoped and the need for palliative care services, looked at palliative care service participation and co-designed a new model of care for palliative service provision. And so, we've got to have the capacity to speak to each of these life phases and each of these compartments of the health system. And of course, when we think about the way our health services system is structured and funded, it becomes even more complex because we have certain health care that is provided or really overseen by our Commonwealth and certain healthcare overseen by our state, and then a real blend. And so it's thinking, what are the levers within that clunky system of financing of healthcare that helps us really push the agenda? And I'll come to some of that. Some of our opportunities have been obviously things like the National Disability Insurance Scheme and then subsequently its review, and speaking into how you can connect disability policy and health policy. When I started in our sphere of disability health, it was fair to say that policy was developed and strategy was developed in isolation. And an example of that was a few years into my job in around, I think, 2011 or so, a national framework for eliminating or reducing restrictive practices, which are practices that restrict the freedoms and rights of an individual, including prescribing practices, was developed. Because part of the role is reducing bad prescribing practices, you'd assume that health practitioners would be consulted in that process. But in fact, that policy was developed by the Department of Social Services. It was developed in complete isolation. And just before it was about to be finalised, someone happened to email me and say, "Did you know about this development?" And showed me, as sometimes happens, a copy of a document that was being developed, a national strategy, which had to that point no consultation with medical practitioners whatsoever. And that was just an example of strategy and the framework done wrong, but it was highlighting the issue that we're thinking in our silos, whether it's this government department or that. What you need is an interconnected policy framework for this group, because without it, you're just perpetuating this siloing and you're not creating the crosstalk between government departments that's required to solve a very complex problem. And so, of course, I jumped up and down and wrote quickly to the government department saying, you can't release this without medical input. That would be, extremely risky for you to do. And fortunately, they were able to undo some stuff and invite medical practitioners to the table. And so we then had a more robust framework that was suitable for everybody and tolerable for everybody. But there are numerous examples of this lack of crosstalk. But we've got to a place now, fortunately, where, for example, our National Disability Strategy has a whole section, Section 6, on healthcare, and preventive healthcare is a big focus of that, outlining the role and responsibility of disability services in provision of supports that enable access to good healthcare and assistance with accessing preventive healthcare, and a responsibility that really needs to be taken seriously. We've had the Royal Commission, Disability Royal Commission in our space. We've been able to feed our data in from the very earliest phases by reaching out to the Commission before it began its hearings, planting in that group a seed, the information that helped them understand healthcare was a big issue for this population and that we needed to have a whole focus on that space. And so they had a major set of hearings related to health and other related needs. And that's been very helpful then in working with the Commission on formulating the recommendations and, of course, working to push government in its response and its implementation ultimately of some of those recommendations. And so that's the phase we're in now. We were fortunate to be funded to develop a national, this is a different piece of work. More recently, the Commonwealth Government invested in the development of a national roadmap. We're able to feed information both from the intellectual disability perspective and the autism and into the autism roadmap to make sure those roadmaps are robust and fit for purpose. The autism one is in its final consultation phase. The other thing to, I think, helpfully understand is what are the other levers in healthcare. For example, regulatory bodies. There's in disability care, there's the Quality and Safeguards Commission. We've worked very closely with them to implement a range of initiatives that help reduce the likelihood of death in disability care related to our deaths data. We've been able to work closely with the Australian Commission on Safety and Quality in Healthcare on a couple of initiatives. Firstly, the psychotropic prescribing and a new clinical care standard, and setting new safety and quality service standard expectations for people with intellectual disability. So you might think also, well, within my space, are there regulatory agencies that might be really useful to speak with to think about how you might progress the work? and elevate it to that regulatory level. Because ultimately, if there are standards in practice, people are held account, and I think that's a really powerful lever. Nationally also, we've been able to work with the Commonwealth Government and argue that we need a better disability data system. And we're really fortunate that funding at a Commonwealth level has now enabled the formation of a new third-generation data infrastructure, the National Disability Data Asset, which will eventually, not initially, but eventually be a fit-for-purpose asset to look at the health and other needs of all people with disability in Australia. And we've been able to work closely with some jurisdictions, specifically developing better health capacity or mental health care capacity, and use our New South Wales data set as it is now as an example, and just say, look, if the most populous state in Australia looks like this, likely yours does as well. And this is the reason for doing something. And they're under significant pressure to do so. Some of you may be aware of the key scandalous finding by the Disability Royal Commission in relation to people with cognitive disability. This case was primarily built on people living with intellectual disability or autism, and the finding was of systemic neglect in the Australian health system. And we've been able to use that effectively to say, this is not good enough. It simply reflects really the other data that we have, I've just shown you, but really this is a very powerful finding that is, I think, a source of, or should be a source of great shame to our government and health services. We've been able to really push the agenda in terms of priorities, and these are priorities that the National Centre has decided it wishes to push in the short term and long term, or medium term. I don't need to go through all of those, but one of the things we've highlighted is the potential for change. We need to understand what the levers are. So we've gone to high-end Commonwealth state agreements, things like the National Health Reform Agreement, to think, okay, we know that's under review now. What is in there that could really help us as we try and think about how we implement the Royal Commission findings? And so we've argued for a specific naming of different disability groups in that National Health Reform Agreement revision, which is being shaped now. And we've tried to work out, well, actually, how do we represent the needs of people with intellectual and developmental disabilities in there? And we've been able to work in our group to develop the implementation component of a curriculum project. We've mapped the gaps in training of future health professionals in this area and published that, and we've been able to get some funding and investment by government to develop a new curriculum across all health disciplines, which we're now trying to implement. And so we're trying to promote that through the conversations with government about implementing the Royal Commission findings. So I could go through each of those, but there are key things that we know need to happen. We've been arguing for a long time. The recommendations for the Royal Commission at the time to really hammer home that, and it's great to be partnering with key lead advocacy agencies to do that work. So I won't bore you with the details because they're probably not of interest, but you'll be able to see them on the slides. I talked a little bit about this new national roadmap to improve the health of people with intellectual disability. This is the first time in my experience, and this started before COVID, so that's the context, that I've really seen our Commonwealth Department of Health engage in a comprehensive co-design approach with people with intellectual disability. And so this has been a real linchpin to the success of new initiatives. As part of that, there have been a number of short, medium and long-term goals set to improve the healthcare of this group. There's been some funding that has been rolled out, including some enhanced funding for specific primary healthcare networks, and we're working closely with them. Funding to implement annual health assessments to pick up the sort of problems in this population and work on proactive healthcare. To develop the curriculum in all health and allied health and dentistry and health-related professions for the future, and to fund the National Centre of Excellence. The centre is a group of people working together. Some of the people have intellectual disability. We work also with family members. So the challenge has been in setting up the centre at UNSW to do co-design well. We have multiple staff members with intellectual disability working with us here at UNSW and in each of the 9 consortium members that are driving the majority of work. The centre is essentially trying to work out what needs to be done to improve the health of people with intellectual disability and lead those initiatives. We're doing this across 4 teams. They're not all led here at UNSW. They're led, this one, Driving Change, is led by our advocacy partners. Driving change is a really important part, and doing that well in a sophisticated way requires leadership. It requires equipping multiple jurisdictions to do that well at a state level, and also requires that national leadership. We're innovating within the health services space by building workforce capability, establishing community practices, and equipping the workforce and growing and developing that. We've got a resources and innovation team developing a new knowledge exchange hub, and that will be pivotal to house some of those products of research and promote them. But it's essentially a one-stop shop for people with disability, families, carers, disability and health professionals that will enable us to communicate and receive information from people as well. Information about what needs to happen, ideas about how to do it well. And we have a research and data team driving the narrative and conversation about the use of data in this space and its value. The consortium partners are listed here. There's a mix of universities and agencies, but there are 57 other organisations that include peaks, First Nations groups, and so on. We're very fortunate to have First Peoples Disability Network as a core consortium member, and lots of other state government investment in as partners and collaborators in, and including regulatory authorities and so on. So everybody has come together for this centre, which is really great to see. They've only come together, I think, because long-term we've invested in developing those right relationships that has created the willingness to say yes when we ask things of them. Some of these people also co-invest in research, for example, in NHMRC partnership grants, and some of them we've done historical work with on committees and so on. So they trust us. So building of that trust has become really important, doing it across lots of different systems, disability, education, corrections, services, etc. I'll just come to a conclusion. We here have had to try and work out how to do this strategically in an uncertain funding environment. I had, until very recently, never been on a permanent contract. All of the work that I've described and all of our work has been done on external funding. None of our staff had received a salary, a firm salary from a university, including myself. So we needed to have clarity of purpose and good fortune. But I do think, and this is just a snapshot from our previous strategic plan, having a clear vision, having a clear mission and a guide as to how you're going to conduct your work, and having clarity around how you'll fulfil it. And these domains just mapped onto our university strategic plan: academic excellence, how we're going to innovate and engage, our drive for social impact, what was it going to look like, was really key. That makes it look really simple when there's a lot of uncertainty. Some of the key pillars I think that have been important, increasingly, I didn't start research as someone experienced in co-design. I started research at a time when you did research on people, and I used to put people in scanners and look at what happened to their brain when I gave them experimental drugs. It sounds quite extraordinary, but nowadays we've moved to a phase where I'm really so excited to have around me people driving our co-design initiatives, people with intellectual disability and other their supporters funded to work here, co-designing new projects with us, working as project staff members and research staff members on those projects. That's an incredible journey. I'd encourage you, we're all on a developmental kind of trajectory to go from wherever you are to enhance your co-design and your skills in that area. I also came in as a purely biological researcher who had to learn a lot from other people about mixed methods research. It started off me not understanding. And frankly, when I talked to qualitative researchers, it was as if they were speaking another language. It was that difficult to relate to initially and to understand. And slowly over time, engaging with lots of different methodologies, I built an awareness of. I'm not saying I'm an expert, but I have people around me who are experts. And I think part of the willingness to sort of value contribution ideas and different ways of working is a really important pillar. As I think I've illustrated the strategy and how important that is, and that you must have a translational focus within that strategy, and how important this cross-sector partnership is. Building that trust over time takes a lot of hard work. And I guess, I'm fortunate to be a person who loves to talk to people, who likes to get out there and have conversations and tries to build those networks. But I'd encourage you, if you are in a similar area, to invest in that. Our inclusive capacity has gradually grown. I've summarised some of the elements of that here. If you're looking for inspirations, web link here from our Disability Innovation Institute here at the university is really good. It tells you how to do co-production in research really well. So I'd recommend that to you. I could keep talking and talking, but I'm not sure that's the right thing to do at this point. I think there are some specific research reflections around translation that I've tried to illustrate as I've gone through. Obviously, translation takes time and money, and I think some things I've illustrated are probably fitting into this. You've got to have the funding. You've got to have a way of funding the research that values co-design, that allows you to have the dollars to translate that into impact for people. You've got to have the time. You've got to build the team. You've got to have tenacity. Our linkage capability has been really helpful in data, big data. You've got to foster those relationships. And I'd like to finish on this one, risk. I've tolerated the risk of having an uncertain future in terms of financially. Many of my staff have had to bear that same thing as we've gone, but also risk in trying to do things differently, in different ways, in embracing that risk. That's fortunate for me. I tolerate that risk environment, probably easier than most. But if you're someone who's afraid of risk, maybe working on how you do risk better. And if you've got the passion and drive, sometimes you can mitigate some of that feeling of discomfort that comes with not knowing what the future holds. And I think I'll just stop there. If you want to connect with the centre, you can scan this QR code to find out more about what it is. Thank you.
Thank you, Julian. That was an amazing, I'm sure, whistle-stop tour of years and years of work to get you to this point. So absolutely fantastic. Thank you very much. Just give you my round of applause from here. I wonder if you could just stop sharing your screen. Actually, no, yes, people may want to just take that QR code. So I'll just give people just a sort of few more minutes for that. We've only got 5 minutes, but if anybody has any questions that they'd like to ask Julian, then please either pop your hand up or just unmute yourself. Actually, I think I probably can see most people now, but if you have any questions, please do just jump in or pop something in the chat if you'd rather do that. But I'm going to jump in with Chair's prerogative, as is my want. One of the questions, there were lots of questions that came to mind, Julian, as you were talking today, as you can imagine, but one of the ones that came in very, very early on, I was interested in you had a map of Australia, and you said there's about 1.8% of people in Australia have got an intellectual disability. And I wondered, so how do we compare internationally and either with sort of numbers and just kind of like the approaches that we're taking with your new centre? Where do we stand in the world?
Yeah. There are some countries with similar healthcare systems that really describe very similar problems to us. There are some places, for example, the UK, who are a bit more advanced in their thinking about policy and service provision for this group, and who have legislated requirements of health services to ensure that they're providing reasonable adjustments in healthcare, for example. and they have more funded services. There are many places that are on the cusp of understanding the health needs like us. Canada is doing an okay job. The US is starting to understand that it needs to do more. Some European countries are doing a great job. Everybody on the whole feels shows that roughly they have between 1% and 2% of their population with intellectual disability when you've got the right interconnected data. Many countries just don't have the data sets or the capability to bring them together at this point.
Fascinating. So we're maybe mid-table?
Yeah, I think so, at this point. But I mean, when you look at Australia, we have tremendous variability state by state. Our eastern states are probably doing the leading work in this area in terms of particularly acute care services provision, but many of our states are falling sadly behind. There's some really good new developments in South Australia, for example. Not very much happening yet in Western Australia, despite really good data in Western Australia, led by the Telethon Kids Institute. Northern Territory, Tasmania lack capacity. ACT has some health-related services.
Yeah. And tell me, I'm very interested. You've clearly had quite a road to Damascus conversion when it comes to co-design and qualitative research, sort of from where you were going to where you are now. What do you think it was that sort of turned you round in that journey?
Primarily, it was the experience of working through the decade of the brain with all of its promise of something dramatic is going to happen here, and we're all of a sudden going to have cures to complex neurological diseases. I was particularly focused on degenerative conditions and realising that wasn't fulfilled, and then thinking, okay, I've got this much time in a career. I have this skill set, which I feel is quite limited. If I was aware of, because I've worked clinically with people with intellectual and complex developmental disabilities for many years, I was aware of the health gap, and this opportunity came. So at that point worked out, well, actually to have the greatest impact in the shortest time that I have available, I'll need to equip myself with X, Y, and Z, and I don't have that. I'm hopelessly inadequate. So, what am I going to do about that? How am I going to hear and learn from other people and partner with other people in that solution?
So a real shift in the kinds of questions that you are asking.
Kind of questions, and I think approaches to work. I come from a research mentoring where it was, really led by eminent people who are absolutely dedicated, but reasonably, some of them were narrow in their focus and methodologies. Not all of them, but some of them were more narrow than others. And I thought, well, that's because of the complexity of this group, their needs across multiple different domains, the complexity of the solutions to their problems, I'd need a much bigger toolbox, I guess.
Yeah, no, that makes perfect sense. Well, that's just about all we have time for today, as we're finishing up sort of in 1 minute's time. Really, that just gives me sufficient time to say thank you so much, Julian, for that, sharing all of that experience over the last sort of few years.
And thank you. Could I just add, I'm the person who comes and talks about it all. There's so many people that just do all of the work. I just get up to say, this is the work that we've done. And there's some people on the call who we collaborate with as well. I've just seen somebody's name flash up there, Janet. Hello, and it's an absolute privilege to lead that. I don't do it all. It's the people here who do it all.
It's all about the team, isn't it, Julian? Always about the team. But no, we're very grateful for you giving us your time today and sharing some of work that you've been doing and the team has been doing. And that leaves me to say thank you very much, everybody, for attending today, and I hope to see you again next month.